So welcome everybody. This is another basics webinar of the EURO-NMD European Reference Network for Neuromuscular Disorders. These webinars are organized in collaboration with the European Reference Network for Rare Neurological Disorders and the European Academy of Neurology. We are all today fortunate to have a guest of the house that had previously delivered a very successful webinar on exercise in neuromuscular diseases, one of our most popular ones, and that is continuing to be seen on demand on our site. Nicole Vert, she works in the rehabilitation clinics of the Radboud University Medical Center, and she is a very good communicator, so we expect to learn a lot today. And as she's almost a part of the family now that she's coming back, I will not prolong too much her presentation because I trust that most of you know her already. Nicole, thank you very much for accepting our invitation, and please enlighten us about fatigue in neuromuscular disorders this time, please.
Thank you very much for the warm introduction, Antonio, and having me today. It's King's Day in the Netherlands, but it's a very good day to tell more about fatigue in neuromuscular diseases. I will share my screen now. Just to check, do you see my screen?
Yes, we do.
Okay. As you can see here, this afternoon, I will tell more about fatigue in neuromuscular diseases as a multidimensional problem. I will tell more about the drama queen. I will tell you how to solve a Rubik's Cube. I will show some vacation pictures and tell you more about the technique of a toilet flush. Just kidding, they all have to do with fatigue. And I will tell you that fatigue is a multidimensional problem, and you can use a multidimensional model to solve it. And the most important thing is that there are different types of people. There are more than 600 different types of NMD in the world, but the most important thing is that there are different types of people. And there are different types of fatigue. I will show you the flush model of Guillaume Millet, a researcher in France. And I will show you some different types of effective interventions for fatigue. And with all that, I propose a multidimensional model. First, let's start with a definition of fatigue. And please don't remember it, don't even read it. I will show it to you because to let you see how complex fatigue is, how many domains, how many factors fatigue has. So it's a kind of a complicated problem. And fatigue in NMD is a frequent but also a relevant problem. More than 60% of patients with NMD experience severe and chronic fatigue. And it has relevant consequences for their quality of life and their social participation. And for not so long ago, it was recognized as a problem. But fortunately, we do now recognize it as a problem, and we have a solution for it. And there was research, and patients was asked, what is the burden of your disease? And of course, muscle weakness is part of the disease burden, but there's more. There's fatigue. More than 80% of patients experience pain. Sleep disturbances are common, and with that, it's very difficult for people to be physically active. And all this is the burden of disease for patients with NMD. So it's more than only muscle weakness. And then fatigue can be primary or secondary. Primary as a primary phenomenon of the disease. For example, in myasthenia gravis or in metabolic myopathy, it can be a primary problem. But especially in many other neuromuscular diseases, it can also be a secondary problem. You can see in the right upper corner the vicious circle of inactivity. When you have a neuromuscular disease, there is a loss of muscular strength. And with that, I showed you before, it's very difficult to be active. So there is inactivity. And as a consequence of inactivity, there is a deterioration of the cardiovascular component, and an increase of fatigue, and with that, an increase of inactivity, etc. So that's the vicious circle of fatigue. And then it's important to know, is the fatigue primary or secondary? Because secondary fatigue is much more easy to treat than primary fatigue. And when your patient has fatigue, please also take a look at the differential diagnosis, because there can also be a problem of the thyroid, a kidney disease, anemia, diabetes, sleep disorders are common. And for example, the excessive daytime sleepiness in myotonic dystrophy type 1. How can we distinguish it? Please ask your patient with DM1, do you feel fatigued inside? Because in excessive daytime sleepiness, the fatigue is not inside. It just, they fell asleep over the day. Sleep apnea is common, and medication can have side effects. Please take a look at beta blockers. They are often used to treat hypertension, but they have not so well side effects for patients with NMD. For example, fatigue is a well-known side effect, but also having beta blockers that decreases the heart rate. And with that, it's very difficult to exercise. So if they are not really indicated, please take a look at other antihypertensiva. The antihistamines they can cause fatigue, but also painkillers like morphine. So take a look at medication too. Then another distinguishing of fatigue. Fatigue can be perceived, or fatigue can be performance fatigability. The first one is the more subjective form of fatigue, and the last one, the objective form. Perceived fatigability has to do with homeostasis and with the psychological state. For example, the level of blood glucose, metabolites, wakefulness, and the psychological state can have to do with pain, mood, motivation. So that's more the subjective part. What do you feel regarding your fatigability? And then the performance fatigability, that can be more easy objectively measured. That's about the contractile function and muscle activation. So the primary fatigue in NMD is especially in the second part. Also good to know is that they are not related to each other. So there's no one-in-one relationship between perceived fatigability and performance fatigability. That's also good to know. Then taking a look at the performance fatigability, that can be divided into central fatigue and peripheral fatigue. Central fatigue has its origin in the central nervous system, in the brains and in the spinal cord, and peripheral fatigue in the, for example, in the muscles and the peripheral part of the organism. And we do not exactly know what central fatigue means. I will come back to that later on. Then it's good to know that there is fatigue in daily life, the fatigue level, and there is fatigue during exercise and activity, the fatigability. And for example, top sporters have a very low fatigability during exercise and a low fatigue level in daily life. On the other hand, patients with NMD have a very high level of fatigability during exercise and unfortunately also a high fatigue level in daily life. And also, all these three groups, the high fatigability group, intermediate and lowest fatigability group, have the same level, tolerable fatigue ceiling level. That means that the people with the lowest fatigability level can have a very high activity limit. They can do many things in daily life. And patients with NMD, they have the same fatigue ceiling as a top sporter, but as a consequence, their work of activity is less. And the aim of treatment is to, on the one hand, lower the fatigue level in daily life, and on the other hand, lower the level of fatigability during exercise and activity to make them top sporters. But I always say my patients are already top sporters in daily life because they are very fatigued in daily life activities. And there's a difference because top sporters like cyclists in the Tour de France, They are top sporters, but they don't have to do their household activities or go to work during a competition. But patients do have their household, do have to do their household and work and care for their family members. And once a patient said to me, I'm a top sporter, but I don't get rewarded for it. So that's also a not so good difference. Then the last thing is about acute and chronic fatigue. Acute fatigue, that occurs after energy expenditure, just like the upper image. It is of a short duration, it goes away, and it improves with rest. And there's a relationship between the level of acute fatigue and the level of energy expenditure. But when acute fatigue doesn't go away, it can become chronic fatigue. And that's not a good form of fatigue, because that's about early exhaustion. It's a more severe form of fatigue, and people often have an aversion to effort. And it's not directly related to physical effort. There's no relationship anymore between the things you do and the level of fatigue you experience. And also, unfortunately, it's not typically ameliorated by rest. So patients say, what I do if I rest or if I act, I'm always experience fatigue. And especially this form of fatigue is a multidimensional concept with many factors. And it's good to know that, just like I said before, people with a high fatigability resistance, the cyclists of the Tour de France, and people with a low fatigability resistance, the NMD patients, they all more or less have the same daily life tasks. And people with a low fatigability resistance, they don't have enough rest. And as a consequence, there is an accumulation of fatigue in daily life. So they are at risk for chronic fatigue. And I will show you later on how you can prevent that acute fatigue becomes chronic fatigue. And how, it's good to know that there are 3 different factors that have to do with acute fatigue becoming chronic fatigue. There is the precipitating factors. Once acute fatigue began, for example, because of an illness or because of an activity, but you can turn back time, you can't do anything about the precipitating factors. Then there are the predisposing factors. That's, for example, having a disease like a neuromuscular disease. And unfortunately, up to now, we cannot do anything about that. And then the most important factors, the perpetuating factors, the factors that make that the acute fatigue becomes chronic fatigue. And these factors are important because they can become the focus of intervention. And you can see them over here in this model built by Kalkman in 2007. And in the model is fatigue in the center. And you can see that physical inactivity is a very important perpetuating factor that can lead to chronic fatigue, but also overactivity, overuse. The second most important factor is pain that can lead to fatigue. And the third most important factor are sleep disturbances. And with all that in the right upper corner, it can all lead to a lower level of social participation. Another thing is that you see that muscle weakness is only an indirect factor. And we also know from research that the level of muscle weakness is not related to the level of fatigue. So there are people with a high level of muscle weakness and a low level of fatigue, and the other way around. Especially people with more or less low level of muscle weakness. These are the people that go to work, do their household, care for their family members, and often the people that have a high level of fatigue. And that raises the question, because the model is for more, is applicable to more conditions, that is fatigue a disease specific or a generic symptom in chronic medical conditions? And these researchers analyzed the results of different trials in NMD, but also in fatigue after cancer, in multiple sclerosis, Parkinson's disease, even chronic fatigue syndrome. And they saw that the fatigue is in 10% of cases disease-specific and in 90% of cases a generic transdiagnostic symptom. So in other words, also interventions aimed at the perpetuating factors can be applied to many different conditions, also many different NMD. So that leads me to the most important thing, that there are different types of people And there are billions of people in the world. And some may have a neuromuscular disease, but it doesn't define their personality. So it's very important to not only look at the NMD, but also to take a look at the person and to separate the person from the disease and to take a look which factors are important that make that the fatigue doesn't go away. And how can we measure fatigue? First, the peripheral fatigue. That can be measured, of course, by the measurement of force or using an ergometer. And watch out, clinicians rarely test for changes in strength after repetitive movements. Or in other words, they ask their patients to give a kind of strength or maximum strength, but that's only for a couple of seconds. But in daily life, you are asked to give strength for many hours. And that's different from the strength tested in the consulting room. You can measure peripheral fatigue with EMG. I will show you research later on. And then central fatigue can be measured with the twitch interpolation technique or by motor cortex stimulation. And what you measure is you ask a patient to give maximal strength, and then you superimpose the nerve, and then you can see that there can be more maximal strength given than that the patient gives. And the difference between the real maximum strength and the given maximal strength is central fatigue. But we do not know exactly what central fatigue means. So you see that the research regarding central fatigue is more or less decreasing, but I think it's still very important to know what's lying behind it, because it's a difference between what you deliver in daily life and what you can deliver. Then the last one, the perceived or more subjective fatigability, can be measured by the rate of perceived exertion and by questionnaires. Then, questionnaires. Please think about how many questionnaires do you think on fatigue exist in the general literature? Please give a moment to think, then I will give the answer. 250 questionnaires. And that was already in 2007, and now we are almost 20 years further, so maybe there are 500, but that's not the most important thing. The most important thing is that only 150 of them have been only used once. So think back on the definition in the beginning, because it's very difficult to measure fatigue with all the different components, and also especially subjective fatigue. So very difficult to measure. Then another form of fatigue or form of measurement of fatigue is impaired coordination. On the left side, you see athletes, and you see that they all have the same coordination. They are very fit. On the right-hand side, you can see the brothers Brownlee during a triathlon competition. And the left brother helps the right brother because he's very fatigued. And you can see the difference in coordination. You can see in his face, in the right brother, that he is fatigued. And that's impaired coordination as a consequence of fatigue. And you can measure impaired coordination. I have a patient and she has an assistance dog, and this dog helps her to measure her fatigue. She doesn't feel her fatigue. And as a consequence, there was very frequently overuse in daily life with an accumulation of fatigue and a very high risk of chronic fatigue. And when the dog measures her fatigue, he's sitting in front of her, and then she knows, oh, I have to take a little rest. And that helps her a lot. She doesn't have chronic fatigue anymore. And during the COVID period, she was wearing a mask, and she said, my dog is not happy with my mask. He is pulling away my mask. And she said to me, I think it's my smell. He uses my smell in order to measure fatigue. But I think that he wants to see her face. And just like the brother in the right brother, he sees in her face that she's fatigued. Take a look at yourself. Your partner often can see you when you're fatigued. It's in your face. And maybe we can use it. Then, as I promised, more information on measuring fatigue by EMG. Last year, we published a study on EMG thresholds during incremental cycling in NMD to use to measure muscle fatigue. Muscle fatigue, that is a common and potentially the most disabling symptom in NMD. And just like the patient before, it's very difficult to detect and cope with in daily life. And up till now, we don't have a very well objective outcome measure for it. And in healthy subjects, we know that during an incremental maximal ergospirometry test, we can use ventilatory thresholds to measure the aerobic capacity. And they are used to determine the workload. However, they are more or less a summary of the body and not muscle specific. And when measuring muscle fatigue, it's very good also because of the asymmetry in patients to measure more muscle specific. So we thought maybe surface AMG could be an objective measurement to measure local muscle fatigue. And we know from previous research that in healthy subjects, there is a large relation in timing between EMG thresholds, so thresholds in the EMG amplitude, and these ventilatory thresholds during cycling. Ventilatory thresholds, there are two of them. The first one is when lactate is accumulating, and the second one is that lactate is accumulating very much so that you cannot breathe it out. And that's the second ventilatory threshold. So we included 24 healthy subjects and 32 people with an NMD. They all performed an spirometry cycling test, steep ramp protocol, and we measured the ventilatory thresholds, the aerobic and anaerobic threshold, and also the EMG thresholds. And we wanted to take a look at the reliability on the one hand, but also the correlation between the timing of these thresholds in patients compared to healthy subjects. First, the reliability. Here you can see the EMG amplitude. It's an example, and you can see the deviation in the graph and two different thresholds in the EMG amplitude signal. And the test-retest reliability was very high for both thresholds, but even higher for the EMG amplitude thresholds. Then the correlation. First of all, of course, there was a difference in the timing in thresholds between patients and healthy subjects, as we expected. The black dots are the patients and the white dots are the healthy subjects. But the most important finding was that, and that you can see in the first EMG threshold, the timing of the ventilatory threshold is in the y-axis and the timing of the EMG threshold in the x-axis. And when the dots are on the line, there's a perfect, there's no difference in timing between the thresholds. And you can see that for the healthy subjects, the EMG threshold was later in time than the ventilatory thresholds. But in the patients, the EMG thresholds were, compared to the healthy subjects, earlier in time than the ventilatory subjects, especially for the first threshold. Or in other words, muscles are more earlier fatigued than can be measured in the ventilatory thresholds. So we saw significant differences in the thresholds between group. And especially the first EMG threshold, so when the lactate starts to accumulate, occurred earlier in time. Reliability was very high. And in future projects, we want to use these measurements to help people detect muscle fatigue in daily life, in FSHD, but also in other NMD patients. And now, currently, we are measuring pain symptoms during cycling measurements, but also strength measurements, EMG measurements again, but also motion analysis. And then we take a look at coordination and also compensation mechanisms. We want to take a look if we can use an EMG, but also motion analysis to capture fatigue. And in my experience, pain complaints are often detected in the muscles who are relatively strong. Muscles who are relatively strong help the weak muscles in their movement. And what we want to do is to detect these compensation mechanisms and to detect the timing when compensation mechanisms are not helpful anymore, but can lead to pain. So I hope that these measurements can help in decreasing fatigue and pain complaints. And what we also did with the results of the DETECT trial, we now know that the first EMG threshold is relatively early in time, especially in patients who are severely affected and starting to exercise. So that means that when patients start to exercise, the bicycle is ahead of the first threshold. So there's a very high risk of the accumulation of lactate muscle pain, muscle fatigue. When we start with the regular 50% of the maximum. So we now tell patients when they start exercise, to start at 30% of the maximum. And we hope, and then when building up very slowly, so start low and go slow, that we can increase the first EMD threshold. And up till now, we were able to help people who weren't able to exercise, to start low, 30% of the maximum, and to build up very slowly, to prevent the accumulation of lactates and to prevent muscle fatigue. And it helps also in their confidence, because at last they are able to build up their exercise intensity. Then go further with the flush model of Guillaume Millet. He's a researcher in France, University of Jean Monnet, and he invented the flush model for healthy athletes. But when I talked to him, I thought it's also applicable to NMD patients. And it's about the filling rate, the rate of perceived exertion, feeling if you're at risk, when you have to stop exercise, when you feel good, about feed forward, feed back, and the valve. First of all, the filling rate that fills the water tank of the toilet flush. And of course, when you are exercising or active, then the water tank fills, and then you get tired. And the rate of filling is, of course, it's about the intensity and duration of the activity. Then the rate of perceived exertion, I told you before, it's a measure of subjective fatigue. That's a very important thing because it prevents overflow of the tank, or in other words, endangering of the organism, of ourselves. And it involves the integration of multiple signals from your body, from outside, and from a variety of perceptual cues. Also good to know that the level of the water in the tank depends on how high is the level of the tank in the beginning. If you have had a stressful day or bad night of sleep, and you start exercising, then the level of the tank is already high. Your rate of perceived exertion is already very high. And then the rate of the increase of the RPA to measure the filling of the tank, that has a very important affective component. For example, when you're afraid to exercise, your RPE will, I think, increase to a more higher level than you are not afraid to exercise. And we know from healthy subjects, when they perform a demanding cognitive task, that their peak power output was 15% lower than the people who didn't perform a demanding cognitive task. So if you have a very demanding cognitive day at work, your RPA will increase to a higher level than without it. Then feed forward and feedback. To measure RPE, you measure your signals. And there are signals from the brain to the muscle. For example, when you are active, new muscle fibers have to be recruited. So the brain sends signals to the muscle, but there also are sent signals from the muscle to the brain. And that helps in measuring the rate of perceived exertion. Then the waste pipe. The waste pipe can help to decrease the level of water in the tank. It empties the flush. It can be, for example, by sleep. Don't sleep during exercise, but before. But you can rest during exercise. When you cycle and get fatigued, you can rest a little bit and then go further. That lowers the level in the tank. We also know that psychological strategies can help. For example, dissociative thoughts during exercise, to take your attention away from the signals, or the other way around. Sometimes it helps to listen to your body and to center to your own sensations. That helps, for example, to maintain the optimal technique, optimal coordination. And we know in healthy people that it helps, for example, to rinse the mouth with a solution containing glucose. I don't advise you to do that every day, but I want to show you that you can help lowering the level of water in the tank. For example, in NMD patients, walking aids, like crutches, can help lower the level of water during exercise. When you use aids in the right way, you can walk for a longer time. And with that, decrease fatigue and increase your aerobic capacity. And Guillaume Millet said to me, when I get an amount of money as an athlete, and I have to choose, what do I want to do? Do I want to exercise more, or do I want advice from a psychologist? I would choose the second one, because we can do a lot with psychological strategies in decreasing fatigue and also in increasing aerobic capacity. Then the last one, maybe the most important one, is the security reserve in the water tank. That's the reason why exercise stops. When the rate of perceived exertion is at a certain level, it's time to stop. It's the time to exhaustion. But sometimes you can use the security reserve. Top athletes use them in the end spurt, but don't use it every day, because it's a kind of a protection to protect the integrity of the body. And when you use it every day, there's a high risk that you damage the integrity of the body. Why do we stop? Because activity is too difficult, or the effort is too demanding, or the other way, the feelings of discomfort overwhelm the potential reward. So there have to be a balance between the reward of an activity and the feelings of discomfort, the golden medal. Then psychostimulants, they can lower the security reserve. Could be, maybe very helpful, but don't do it, because the security reserve helps you to protect the integrity of the body. So only use it sometimes. For example, a patient said to me last week, when I go a day out with my children, I use a security reserve, and I know that I have fatigue the days after, but I do it once a month or once every second month, but not every day. There's a competition and there is daily life. Then, as I showed before, there's a level of fatigue in daily life. And what you want to aim for is a high baseline fitness, a high aerobic capacity in daily life, and low demands, low peaks. Just like a valley in the mountains, and not a mountain in the Netherlands. So a low level of aerobic capacity and highly demands and high peaks, because the body loves structure and don't want high peaks, high demands. And that you can do, for example, by exercising. With exercise, you can increase your aerobic capacity and take a look at your daily life demands in order to not have many peaks in daily lives. And with that, you can lower the fatigue level in daily life and also lower the fatigability during exercise. And think about, when starting exercise, start low and go slow. Better to start at 30% than at 50% and increase very slowly. Not filling up the water tank too quickly. And also very important, listen to your body. A girl of 6 years old was asked, what is pain and what is fatigue? And she said, pain and fatigue, I think that's when your body talks to you. Wonderful, because it's true. In case of acute fatigue and acute pain, they have a meaning, pain and fatigue. They warn you. Think about helping the integrity of the body. But it's not the case in chronic fatigue and chronic pain, because I said before, there's no relation in chronic fatigue and chronic pain between what you feel and what you did. But in acute fatigue, listen to your body and prevent chronic fatigue and chronic pain. And you can use, for example, the Borg scale on the left-hand side. And I saw this sentence last week. In training, you listen to your body, and in competition, you tell your body to shut up. And that's the case for top athletes. In training, they listen to their body so that they don't build up the fatigue of their daily life. And in competition, they use the security reserve. And of course, patients are not top athletes, but they do have to know when they are in competition, when they are a day out. Okay, that's okay to use the security reserve and to know that you have to take a rest afterwards. But don't be a top athlete in every daily life, because life is not a competition, to prevent chronic fatigue and pain. Because this research shows also an important component, the use of psychostimulants or pain medication. These are 3 groups of cyclists. One group gets fentanyl medication, so that's a pain medication. And it's the uppermost group. And you can see that they were all asked to cycle for a distance of 5 kilometers. That at first, the fentanyl group had a very high level of power output in the beginning. compared to the control group without medication. And there was also a group with a placebo medication. But in the end of the competition, they had a lower power output. So in the beginning, also for patients, it helps to lower the level of pain by pain medication. But in the end, you don't get the reward and you will only get worse. Also, a very important finding is that the placebo group also had a higher power output in the beginning and no lower output in the end. So that's maybe the importance of psychological strategies, which are not harmful. And please, as patients, use arm support, use walking aids, use orthoses, smartwatches when indicated. Don't be afraid that aids, that you become lazy by using walking aids, because they help you to lower the fatigability during exercise and activity. So you can increase your work of activity, and with that, the work activity, the aerobic capacity, and lower the fatigue level in daily life. So don't be afraid to use them, because cyclists also use aids for cycling, the most lightweighted bicycles, most expensive bicycles. And are they lazy? No, they are not lazy. Armstrong is maybe not a good example regarding to psychostimulants, but that's another story. And I think it's very important to educate your patients, because I see my patients once or twice a year, and all the other days they have to do it alone. And when your patient understands the principle of fatigue and what he or she can do with fatigue, it helps, because then they can better cope with it in daily life. So educate your patient. That helps understanding fatigue. Now the last part, I'm going to the interventions. And these are only examples of trials with a positive effect on fatigue. And happily, they are increasing, because fatigue, especially chronic fatigue, can be treated in NMD patients. Two examples of multidimensional disease-modifying rehabilitation interventions in FSHD and myotonic dystrophy type 1. The first one, the FSHD trial, was based on the model I showed you before, based on a model with perpetuating factors of fatigue. It was my own PhD project, and we thought that with bicycle exercises on the one hand and another group with cognitive behavioral therapy, we could break the vicious circle of inactivity. What we did was the groups received 16 weeks of cognitive behavioral therapy or 16 weeks of cycling exercises, and we had a usual care group. And in the end, it appeared that the cognitive behavioral therapy only received on average 2 to 3 sessions. So that was already enough to break the vicious circle of inactivity or overuse. Cognitive behavioral therapy is a therapy given by a psychologist and aimed to change dysfunctional cognitions regarding fatigue. For example, my fatigue doesn't go away. I cannot do anything about it. So to change dysfunctional cognitions, but also it aimed to change the insufficient coping with the disease, to decrease catastrophizing if it was applicable, deregulation of sleep. We ask patients to adhere to structured day and sleep times, focused at deregulation of activity. Think back on the valley in the mountains to have a more structured activity level during the day and week. And when applicable, it was aimed at low social support and negative social interactions. And the cycling exercises were 3 times a week for 30 minutes. And what we saw was that they both had a positive effect on experienced fatigue, on the level of physical activity, and cognitive behavioral therapy also was effective for sleep quality, disease progression, and social participation. There was a number needed to treat of only 2.3 for the cycling group and 1.3 for the cognitive behavioral therapy group. Or in other words, only 1.3 patient had to receive cognitive behavioral therapy to treat one patient of his or her fatigue. And 70 participants in the cycling group and 76 participants in the CBT group continued exercising years after the trial. So it had a very long effect. And as I said before, it had a disease decelerating effect. We measured the fatty infiltration of the muscle tissue. What we saw was on average in 1 year an increase of 6% of fatty infiltration in the upper leg muscles. And after aerobic exercise training of 16 weeks, that increase was only 2.5%. And after cognitive behavioral therapy, only 2%. So we saw a deceleration of the fatty infiltration, a disease-modifying treatment. Then the other trial was in myotonic dystrophy type 1, also based on the same model with two differences. We had to add reduced initiative, a common symptom in these patients, to the model, and also myotonia to pain in the model. In this group, cognitive behavioral therapy was combined with activity. So there were only two groups, a usual care group and a CBT group. It was published in the Lancet Neurology and based on the model. And here you can see the modules in the optimistic trial in DM1. And what was very important to know, and I think the most important module, was that it all began with a compensation of the reduced initiative, if applicable, very important in these patients, to take a look how they can adhere to the therapy. And then also regulate sleep-wake pattern, graded activity, change dysfunctional pain behavior and beliefs about fatigue and DM1, and also a social support module. And to our positive, very positive was that the adherence was very high. We didn't expect it from these patients. A complete measurement of this international trial of 225 patients, of in total 255, were the fully recruitment in only 13 months. So the first module was very important. If you can compensate for reduced initiative in these patients, you can get very positive results. The effect was an increase in DM1 active, an increase in distance walked in the 6-minute walk test, increase in a level of physical activity, and a decrease in a level of fatigue and daytime sleepiness, so also effective on fatigue. Here you can see the change in muscle fat fraction in DM1. No difference between the usual care group and the cognitive behavioral therapy group over 10 months. But when we take a look at the change in muscle volume, we did see a change. In the usual care group, there was a decrease in muscle volume, and in the CBT group, an increase in muscle volume. So also a deceleration of the disease progression, because the fat fraction also changed because of a change in muscle volume. But also interesting that there is a difference in FSHD and DM1. In FSHD, an effect on the fatty infiltration, and in DM1 on the muscle volume. So it's we were able to cure fatigue in the maybe most heterogeneous disease of NMD, myotonic dystrophy type 1. We were very happy with it. And what we saw is maybe a kind of a holistic multidimensional approach. We call that reverse engineering. Normally, when trying to set up a trial, we begin at DNA, then go to the lab, and then to animal models, and then animal studies, and we hope to invent an effective medication. Not very positive up till now, but now we see that we have two trials based on a model in human people based on fatigue complaints, with a very positive effect on disease progression. And maybe that also helps us to invent medication, to take a look what is lying behind it. And I can give another webinar, because I think it's about epigenetics, all the factors around us that are of influence on our DNA, like activity, like a positive feeling, like sleep quality, etc. And my colleague, Professor Basile van Engelen in the Radboud University Medical Center, calls it a forensic approach, or back translation. Sherlock Holmes uses it. He says, in solving a problem of this sort, the grand thing is to be able to reason backward. There has happened something and we have to reason backward. And it's a very usual accomplishment and a very easy one, but people do not practice it much. So I advise reason backward to see what helps and what helps not. So a multidimensional approach for heterogeneity needs in patients with NMD, because they are all different from each other, just like the Rubik's Cube. and not one size fits nobody. If you want to treat people equally, you have to do it in different ways. Just take a look at the three human at the left side. And I'm happy that I also work in a rehabilitation center, Klimenel in Arnhem, but also in a muscle center in the Rabat University Medical Center. And we work with a very heterogeneity group with nurses, therapists, neurologists, rehabilitation physicians, basic researchers, radiologists, etc. And we also apply reverse engineering, and we learn from each other. So in the last 45 minutes, I have told you more about fatigue in NMD as a multidimensional problem. I've told you more about all the different types of people, the multidimensional problem, the toilet flush technique. I've advised you to educate your patients, and that patients have to have a high level of capacity in daily life, a low daily life fatigue, and low demands in daily life. And of course, fatigue is a multidimensional problem, but there's also a multidimensional solution. And I'm very curious if there are any questions.
Well, yeah, you have questions, Nicole. And this is being an excellent opportunity to really exchange again important ideas about how to treat things that are common but difficult to treat. And I think that your contribution, as always, has been very inviting. So someone who has asked if there is a genetic predisposition for fatigability.
Yeah, thank you for this very interesting question. I think there is, at least in certain groups. We are aiming to now research the level of fatigability in metabolic myopathy patients, because in metabolic myopathy patients, there are different genetic errors in their DNA, and we think that they have a consequence for the level of fatigability. And what we want to do is to measure aerobic capacity, but also muscle fatigue in these patients, to take a look if there is a difference in the, for example, also accumulation of fatigue in these patients, which can be linked to genetic error in the DNA. Regarding other types of NMD, like the muscular dystrophies, I do not exactly know. For example, in FSHD, we know that the length of repeat is of influence on the severity of the disease, but subjective fatigue is not related to it, but maybe objective fatigue is. And then it's, yeah, maybe interesting to know if there is more relation between the genetic predisposition and the objective fatigability. So an interesting question to take a look at in future research.
Excellent, thank you. So the next question has some relation with DM1, and our Chandra Tomas Mora, she asks if weight training can be appropriate for patients with DM1, and how to measure the physical working and the most adequate level.
Yeah, thank you. Very relevant question. DM1 is, as far as we know, up to now, a disease in which strength training can be effective, for example, also for the hand strength, but how to apply it. The most important thing is to begin early, already in children with DM1, already in children with NMD, begin early with strength training, because it is especially effective when the muscles have a relatively good strength. And how to measure the physical working, when muscles are able to move against the gravity, or in other words, an MRC scale of at least 3, they can be exercised with muscle strength training. Because when they cannot move against the gravity anymore, then there is an impaired coordination, and other muscles help the weakened muscle to move, and then there's a very high risk of pain complaints. So the movement has to be applied with a very well coordination in order to apply strength training. And when applying strength training, a very high number of repetitions and a low amount of the weight. Also start low and go slow, just like aerobic capacity training. And how to measure the physical working? Yeah, maybe start already with a human body, and with moving the human body. The arm also has an amount of weight. And when that goes well, no muscle fatigue after 24 hours, patients can apply their daily activities, then you can slowly increase the level of strength training. But very important, take a look at the coordination during the exercises, because when the coordination is not well, there's a very high risk of pain complaints. And especially in DM1, strength training can be effective.
Okay, thank you. So the next question is from Dr. Josep Ramesh. So we have illustrious attendants. He asks about the treatment for central fatigue, namely for the central fatigue that happens in patients with DM1.
Yeah, as I said, the central fatigue has a very high influence on the strength in daily life. And it's a difference between the strength you can give in theory and the strength you give in the practice. And we know indeed in DM1 patients that the amount of central fatigue can be very high. And sometimes one says they are not motivated, but patients are motivated, but it's about and difficult with the initiation of the movement. So how to treat it? These patients have to have more help than other patients. You have to help them in coordinate their movements, but also in coordination their exercise. What I do when I prescribe exercise interventions to DM1 patients, I call their physical therapist and ask, can you call the patient to start up the exercise, and not asking the patient to start up the exercise. That's one thing. And the other thing is that I think central fatigue has also to do with anxiety of exercise. Patients are afraid that they damage their muscles during exercise. What I saw in the maximal cycling ergospirometry test in NMD patients was that the first test, they were all very afraid. Can we do it? Can we cycle to a maximum? And the second time they say, we are now confident that we can do it. And it's also about central fatigue. So help your patients not be afraid to exercise. Also start low and go slow, because when you start low, then patients will succeed in exercise, and that will help them in confidence. So start low and go slow.
Thank you. Vera Verhage would like to ask if there are differences in NMD patients on the ventilatory thresholds and EMG signals when the test is performed on a cycle ergometer for arm and legs, and if you do you see other compensation in that case?
Yeah, also interesting question. We performed cycling measurements to detect the signals during arm cycling and leg cycling, however, only in healthy subjects. And we did see a difference, but that's, I think, also because in the leg muscles, there are more type 1 muscle fibers with a higher fatigue level. And in the arm muscles, there are more type 2 muscle fibers, which are more easily fatigued than the leg muscles. So we did see a difference. Another difference is that during arm cycling, you use less muscles. So your heart rate don't increase to a high level compared to the leg muscle exercise. We now perform arm and leg strength measurements with motion analysis and EMG, but I don't have the results yet. And that's also in NMD patients. And what do I expect? Is there a difference on the ventilatory thresholds? Yeah, they are more later in time during arm cycling, the ventilatory thresholds, and earlier in time, the EMG thresholds in arm cycling compared to leg cycling. And do you see other compensation? There's a higher risk of compensation or harmful compensation mechanisms in the arms, because the freedom of movement is higher in arm cycling compared to leg cycling. But I think there are both compensation mechanisms, but they are higher for the arm muscles than the leg muscles.
Thank you. And next, and probably the last question, will be by one of our very active patient representatives in the network, Madeleine Kronman. She states first that low sleep quality has an impact on fatigue, and if it would be helpful to start with sleep medication, or is this a no-go in neuromuscular disorders and we should just start exercising? I know half of the answer, so but you please give the rest. Thank you.
I will give the rest. It's just like pain medication. Pain medication can be very helpful in an acute situation, for pain after surgery, for example, or after an accident. Then we know that the pain and the fatigue will go away. It's acute pain, it's acute fatigue. But when we use pain medication in chronic pain, then there's a high risk that pain will not go away in days or weeks, and that we have to use pain medication for a long time, and that there will be very high side effects. And the same is the case for sleep medication. When there is a reason, for example, you are in a hospital and you sleep very bad, but it's only for a week, then it's okay to use sleep medication because it helps you to rest during the night. But when the sleep quality is low for a very long amount of time, I would say take a look at the perpetuating factors of a low quality of sleep. And I always say the sleep at night is the reflection of the day. When you sleep bad at night, very often the cause is in the day. So maybe you have not a structured day during the week, or you have too demanding tasks in the day. And when you have a bad sleep quality, take a look at the sleep rules. For example, no smartphone, no use of smartphone, of television before going to sleep, no coffee, etc. And also adhere to structured day and night times. And don't try to sleep during the day or only a small amount of time, but because when you sleep during the day, your sleep quality at night will be worse. So first take a look at perpetuating factors before starting medication. And when you use medication, only for a short amount of time.
Thank you. I would just add, if you allow me,
of course.
That it's also important that some patients with respiratory impairment be much wary of using sleep pills, because many of them cause muscle hypotonia, so it causes weakness of the muscles, let's say, during sleep.
Agree. Yeah.
Okay, so we are going to finish with one from Dr. Joseph Cames again. He wants to know how to distinguish peripheral physical fatigue from exercise intolerance and from chronic fatigue syndrome. That's an heavy one.
A heavy but a very interesting one. I wish that I was able to distinguish primary from secondary fatigue, to distinguish the fatigue from the NMD from the fatigue secondary, so the fatigue as a consequence of disuse. And up till now, we are not able to distinguish both things, but we can take a look at perpetuating factors like overactivity or inactivity, bad sleep quality, because when they are there, there's a high risk of a high amount of secondary fatigue, so of exercise intolerance. And maybe with the measurement of the more objective fatigue, the EMG measurements of the muscle fatigue, we are more able to distinguish the more objective peripheral fatigue from the exercise intolerance. And then also an interesting one, the chronic fatigue syndrome. As I said before, 10% of fatigue is disease specific and 90% is transdiagnostic. Chronic fatigue syndrome has an overlap with the fatigue secondary fatigue from NMD. And it's maybe a bit strange, but because there's a high overlap in perpetuating factors, for example, over or under activity, bad sleep quality. And that's also why cognitive behavioral therapy is effective for chronic fatigue syndrome and for NMD patients. But yeah, we cannot distinguish up till now the peripheral physical fatigue, this primary fatigue, from the secondary fatigue from intolerance. And I hope that we can do in the future, because then we can help patients further in their exercise programs.
Thank you very much, Nicole. It was, as usual, very interesting, and I think that people will learn lots from today's webinar that can later be seen on demand on our website. Before I switch off, I left on the chat the links for our feedback form. One link is specific for patients or carers of patients. The other is for the rest of the audience. That's another innovation in our webinars. And so please do fill them. That helps us a lot to improve our educational activities. Thank you, Nicole. I hope to have you very soon again with us in another session. And in the meantime, thanks a lot for your very powerful and valuable contribution. Thank you.
Thank you very much, Antonio, and thank you all for watching. Till next time.
Bye. Bye.
Bye.